Hello, everyone. Today we will be talking about the role or the potential role of estrogen as part of our skincare. And we will try to evaluate if these active ingredients provides you a net benefit as an anti-aging, or helping your skin to restore to healthier skin, or if we should give priority to other active ingredients with better record, better efficacy, and better safety profile. So let's start with some basic in estrogen biology. And let's start saying that, there are 4 types of estrogens, and they are listed here in the screen. The most important one, the most potent one, is 17-beta estradiol, and you will hear me talking about this during this presentation. And this is a hormone that is produced in our ovaries until menopause. Estrogens basically changes. They change the function of the cells by interacting with estrogen receptors. And there are 2 of them. There are estrogen receptor alpha and estrogen receptor beta. When the ligand or the hormone, the estrogen, bind to this receptor, they basically trigger the dimerization, and this dimer, this complex, migrate to inside of the nucleus, where they bind to a specific area in the DNA called estrogen response element, and they trigger the expression of different type of genes. So most of the cells in our body contains the estrogen receptor, either alpha or beta or both. That means that several different functions in our body are regulated by estrogens. This is a list of some of them, as you see, it goes from homeostasis, proliferation, energy balance, glucose metabolism, liver function, lipid metabolism, brain memory, development, repair, bone growth. So basically, because the estrogen receptor is expressed in all the cells, or most of the cells in our body, in theory, all of these cells and functions of these cells can be regulated by the interaction with estrogen. So this is a small, comment before we go into the nitty-gritty of estrogen in skincare. It's like our skin, we have to remember that our skin is an endocrine organ, and it's able to produce several hormones, including estrogens, as well as androgen and glucocorticoids. The production is controlled via glucocorticoids, growth factor, cytokines, and they all basically what they do is they modulate the function of aromatase, which is the key enzyme to produce estrogens in our skin. So basically, our skin has the capacity to produce estrogens locally, and supplement, or for the estrogens in the skin to produce the results that we are looking for. So first question will be do we have estrogen receptors in our skin? So this basically will validate the use of topical estrogen as an active ingredient if this has some anti-aging effect. And the answer is yes. We have estrogen receptor, mainly beta, in the epidermis, as well as in the dermis, in hair follicles, as well as in sebaceous glands. So if the receptor is present, hence the response to estrogen can be produced when estrogen is present in the skin. What is very interesting is the estrogen receptor levels changes in different parts of the body, and the highest level of the receptor are in the face, lower limbs, and around the genitalia area. So pretty, unique distribution. So let's talk now about estrogen and human skin. What they do, we know that estrogen increases skin moisturization or hydration, and this is done via induction of the production of your own skin, hyaluronic acid, mucopolysaccharides, and sebum production. So there is, basically estrogen modify the function of the skin. They also improve collagen levels, both in quality and skin thickness. So you produce better collagen, which produce, healthy, stronger collagen fibers, and basically produce thicker skin, enhance vascularization, and also promote wound healing. So that is what we know about estrogens and skin. So what happened in menopause? So the beautiful thing about estrogen and menopause is we have, an in vivo model that shows us what can happen when the levels blood levels of estrogens decrease significantly, and we can, like basically figure it out what is the role of estrogens in this model, and see if we can recover, this by applying estrogen to our system. So we know that around 60 to 70% of menopausal women report problems in the skin or report changes in the skin health. And skin drying is the major symptoms. They always complain once that they get into menopause, that the skin is getting drier, that they never had dry skin, but this time, like it's something that is very unique, very significant for them. In a study that was done using postmenopausal women, pretty significant number of them, they showed that there was a decrease in collagen at a rate of 2% per year for the next 15 years, so since the moment that they start menopause, and a decrease in skin firmness and elasticity. So untreated menopause can produce, changes in the skin, not only at the level of skin dryness, but also at the level of skin firmness and elasticity. So based on this, the next question will be, okay, we know that estrogens have a very important benefit for the skin, that during menopause we lose this benefit. What happens if we do hormone replacement therapy? Do we recover the healthiness of the skin? We do recover, skin hydration, elasticity, and moisturization. So what we have seen is like, when women with postmenopausal women are using hormone replacement therapy, the texture of their skin improve, hydration and collagen content, as well as viscoelasticity improve. There are a couple of randomized controlled trials that were done using, for 12 months, a very significant amount of time using oral estrogen, and they show an increase of 30% in dermal thickness. So this reflects production of new collagen and healthy collagen, and some of them, some improvements in skin elasticity. The collagen role is very, very clear. The improvement in elasticity is not that clear, which is not surprising because recovering skin elasticity or producing more elastic fiber is not an easy task to accomplish. There is another study that showed that oral hormone replacement therapy for 6 months increased collagen fibers by 6.5% with no changes in elastic fibers. As I say, it will depend on what type of doses and what type of estrogen they are using, and the way of administration. We will see in the data that also affect basically, the results. There were effect on wrinkles. The effect on wrinkles were less clear. It should be, an effect on wrinkles when we are looking at better moisturization and collagen. So the wrinkles appearance should be decreased. And they also, there was a study that showed improvement in the severity of wrinkle, but this is after 5 years of hormone replacement therapy. So as you said, we say, estrogen is good for the skin. Lack of estrogen during menopause produce several skin changes, and hormone replacement therapy can, resolve some of these issues. So the question came is if this is, if estrogen, it has this very marked pattern in which, help the skin health and the skin as a potential anti-aging, because does affect collagen and hydration and hence inflammation. The question is, can we use estrogen as a topical ingredient and see if we can restore, age or photo age or mature skin appearance by using topical estrogen. So what we will see right now is a collection of all the peer-reviewed communication that I could find in PubMed, in which they talk about the use of a topical formulation or a topical patch using different forms of estrogens applied by different times, and see if they can, see some effect or not. So I try to summarize the main taking of each of these papers, which will be in orange or kind of yellow in your screen. So let's start with this. So the study is started in 1987. This is a study with 16 patients for 12 months, and they did, a lower abdomen application of estradiol gel, and they observed in the place of application, so in the abdomen, an increase in collagen. Later on, another study using a small amount of subjects, 14 for 3 weeks, so smaller time, but using, a lower dose of estradiol, they also show a thickening in the elastic fibers in 50% of the subjects, and an increase in epidermal thickness in 29% of the subjects. So when we talk about this, we say increase in this, or like improvement in this amount of, in this percentage of subjects. We don't know if the improvement is significant, is mild, is very small. So we just know that these subjects, half of the subjects, so 7, improve elastic fibers, and less than 7 basically improve epidermal thickness. We will continue with this analysis. Another study with 18 subjects. They use 17 beta estradiol. Remember, this is the most powerful estrogen that we have, and this was a patch. And there were no significant differences in dryness, scaling, bruises, scalp scaling, a number of lentiges, a number of seborrheic keratosis in this patient. So at least, they show no differences here. Another study, now using a very small amount of subjects, 8. So this is almost like a case report, but using 180 days. They use, they apply the 17 beta estradiol in the forearm at 2 different doses. And they observe no statistically difference linked to skin conductance. So basically hydration and elasticity and distensibility. So again, like another study that showed no effect of estrogens in skin health, at least under the condition that this, researchers used. A study using 28 subjects for 12 months, using a small dose of 17 beta estradiol. This is a little bit bigger than before. We saw, they saw an increase in collagen, a significant increase in collagen of around 5.1%. And I want to make a point here, like the fact that this is statistically significant with respect to the control group or the placebo group doesn't mean that it's clinically relevant. We can see, numbers that are statistically significant, but maybe, 5% increase in collagen is not enough for anyone to perceive an improvement in skin thickness or to perceive the benefit of this. So this is important when to differentiate, what is statistically significant and what is clinically relevant. Another study, this for a longer period of time, for 6 months, using 18 subjects. They apply a cream containing estriol and estradiol. Like there were 2 different formulations, and they saw some improvement in vascularization, firmness, and elasticity, moisture, wrinkle depth, and pore size. So this is this gives us an idea of, how much we need to wait, how long we need to wait to see effect with estradiol. Like usually we say when, with retinol or retinal, you need between, around the first month you will see improvement in texture, and later on you will see improvement in pigmentation and wrinkles and firmness and elasticity. So around, 12 weeks, you can start seeing significant effect. In this case, we're talking about like 6 months. So very long period of time to see effect of estradiol as an anti-aging. This is another study. They use, 0.625 milligram of conjugate estrogen cream, and they saw a significant increase in skin thickness, fine wrinkles, fine lines and wrinkles, no statistically different in roughness, laxity, and pigmentation. Another study for 3 months, they saw, increasing collagen in the size of application. So I think, for what we are seeing right now, the collagen part is pretty clear that you can improve, the levels of collagen. The question is this clinically relevant? And a study done in 1995 using 15 subjects for 12 months. They apply in buttocks, abdomen, arm, inner forearm, and outer forearm and neck application. So different sites of application. And they saw an increase in skin thickness and sebum production in all of these applications. So kind of like they were trying to figure it out if the site of application will change, what you're seeing, and all of them respond very similar. We saw another study, there is another study here showing, with 17 beta estradiol, an increase in collagen in the site of application. And as well as, this study in 1996, they show an increase in thickness via collagen 3 and elasticity with decrease of the depth of the wrinkles and the pore size. So I want to make a point here. In this paper, they show there is an increase in collagen 3, and collagen 3 is what I call the emergency collagen. It's produced, when you are repairing the tissue, but the best collagen that you want to produce, the collagen that is they provide you the strong firmness, is collagen 1. So you want to replace your collagen 3, which is your emergency or repair collagen, by collagen 1 as you are, basically moving along the process of rejuvenation. So this is a 6-month study. It could be that this is, we don't know, this will be replaced by collagen 1 following the process of repair, or, we will see a collagen 3 deposit, which is fine, but it's not the best that we can do. Like retinol, basically what it does is induce collagen 1. So that is what you are looking for. That is the reason why your skin is so firm when you are using retinol. Okay, so another study here, now using only 9 subjects, and they were using, they use a patch, and they show an increase in wound healing and decrease in the wound size. So things related with repair, tissue repair. We know that estrogen plays a role in tissue repair, and an increase in collagen. We also observed in this study that was done for 6 months, a significant decrease in skin surface lipids, and an improvement in epidermal hydration, elasticity, and thickness. So, very mixed signals of what estrogen does in the skin. Another study in 2003 showed 22% increase on epidermal thickness when using this type of estradiol cream. Thickness, remember, epidermal thickness is like, as we age, if we age chronologically, our epidermal thickness will decrease. If we age due to photoaging, it will increase. So you have that difference there. In 2005, I studied just for 2 weeks using, the application of 17-beta estradiol in the buttocks, show an increase in the messenger for collagen type 1. So that suggests that they will be deposit of collagen type 1. It's important to remember that when you use, when you measure the messengers, you are measuring the first step in the production of collagen. It doesn't guarantee that you will have deposit of collagen in your skin, but it shows you that, at least the process was activated. And you have also, increase in tropoelastin. So again, the same comment, and fibrillin 1, which is critical for the formation of the healthy elastic fiber. They also observe a reduction in MMP1's level, which is great, because it means that if you are showing, if you eventually will produce collagen and decrease the level of the enzyme that destroy collagen, you have a better chance of increasing skin thickness and firmness. In 2007, this author show an increase in epidermal thickness and collagen levels after 16 weeks of application of cream containing estradiol. We also observe, another, increase in collagen but in sun-protected areas. So this is very important because, like most of us, we have a certain level of photo damage because we expose our skin to the sun radiation without sunscreen for several periods of our life. So the fact that this, only was able to show increasing collagen only in the sun-protected area suggests that the mechanism that trigger photoaging may be, messing up with the estrogen capacity, or maybe the damage is too much that a topical estrogen is unable to produce benefits in the skin. We also observed, in this 2009 study, an increase in skin elasticity. Again, significant increase in skin elasticity of 3.2%. Is that clinically relevant? We don't know. We don't know if the subject actually felt that, or if this was translated in something that was visually observed by some other people in the face of these subjects. We also observed, statistically significant increase in epidermal thickness, which, with several other changes that are linked to a healthy skin after 24 weeks of treatment. In 2012, a study with 40 subjects showed no difference in the MMP1 expression. So that contradicts what we observed, what was reported in a previous study. So I don't know if you're getting, this, the reason why I'm going in this very lengthy explanation of all these papers is because the results are sometimes contradicted. And yes, we can justify different site of application, different lotions, different cream, different formulations, and different type of estradiol. But we started in 1995, if I remember well, doing studies about this, and we still don't have a kind of like a well-developed protocol to apply this to get very reproducible results. So in 2013, there was another study with 15 subjects, and it showed an increase in the production of hyaluronic acid by 17-beta-estradiol, which was associated with another study that basically in the site of application, they improve skin texture. We're getting very close to the end of these studies. We saw, another study in 2017, which showed an increase in collagen 1 and collagen 3 in the site of application. This basically study showed that using a different type of estrogen, and this is a cream around the eye, so result at week 10 with an improvement in dullness, an improvement in skin dryness and laxity, an increase in estrogen receptors signaling on dermal fibroblasts. So kind of like the dermal fibroblasts, when using this product, they express more estrogen receptor. Is that a good thing or a bad thing? I don't know. But this is what happened. Now, I want to make a point here. It's like this is week 10. So this is an eye cream. I have used and I have designed eye cream that produce results in 2 or 4 weeks. Not basically transforming you in your 20-year-old, self, but improvements in redness, improvement in texture, improvement in hydration. So I'm not willing to wait 10 weeks to see results with an eye cream because it contains some form of estradiol. I think it's a lot to ask for someone to wait to see results in dullness only. And finally, I promise you, this is the last one. So a study done with 31 subjects for 12 weeks, so 3 months. They basically, again, this is the same commercially available product that is an eye product. They saw improvement in the periorbital area in 84% of the subject. 3 out of 31, so 9.7% of the subjects had a score that is very much improved. So all the rest, we don't know the level of improvement, but only 3 out of 31, they show this significant improvement, the wow factor, or what I like to call the girlfriend factors, like when you can notice that something has been done to your skin. Okay, so let's summarize this painful review of all the clinical studies that were done using different forms of estradiol in different type of locations and different formulations. So what we can conclude about this? So like these are different, there are differences, in clinical studies design, active ingredient, place of application, to mention some. So this is important. It's very hard to compare apples to apples because we are not apples to apples. We have apples, oranges, and bananas. Adverse events were rarely reported. And this is something that I'm very interested in because we are playing with hormones. And every time I'm very cautious when it comes to hormones. I was probably one of the few people that didn't jump into the wagon of melatonin, as an anti-aging, because I'm really concerned about us manipulating hormones. So I was surprised that the adverse events that were rarely reported among the studies, and if they were reported, were very mild. And keep this on a pin because the reason why I'm making this point is because of it will come in a couple of slides more. There were no systemic effect or adverse events by topical estrogen. But when you read, when you start reading the discussion of this, some of this peer-reviewed communication, you can observe that this author also observed improvements in places that were not the application site. So basically you put a patch on your hand and you see improvement in your skin, in your face. So how this happened? It's like this, the estrogen is moving through your skin or goes into circulation and basically get redistributed to the rest of the body. So this is a very important point to touch, because when it comes to skincare, you don't want your skincare to go into circulation. You want your skincare to stay in your skin and do not be fully absorbed basically into your circulation. And some studies, when I was reading, basically the small print in these studies, talk about the use of oral progesterone to avoid endometrial hyperplasia. So there is a concern about applying topical estrogens, as a skincare that can produce effect at a systemic level and produce, changes in your endometrium. So remember that we talk about absorptions? I say, like, remember this point. So what is the thing with topical estrogen absorption? Because for estrogen, to produce an effect, it should be absorbed. So what they observe is like the site of application, like this study that was done with different sites of application, and they say that the absorption is the same. So they measure basically, but this is the thing, they apply in different places and they measure the level of estrogen in circulation. So now we are talking about something that is going into circulation. So it's kind of like, again, like to me, it's like, ooh, it's a red flag, it's an alert sign that is beeping, because what is a skincare is basically with the potential of going into circulation. There are, like some other studies kind of like figured it out what is the doses that you should be applying daily to be able to, guarantee basically the absorption of estrogen, and do not leave a lot of estrogen on the top of your skin, because like there is a number of reports that has been filed to the FDA describing the unintended transfer of estrogen to children or pets from the skin of women using topical estrogen. So this is, like we have two issues here. We have the issue of absorption and going into circulation, and we have the issue of like not absorbing or excess of estrogen staying on the top of our skin, active estrogen that can be transferred to kids and to pets, producing effects, because this is a hormone. So this is something to consider. Something that I found very interesting about absorption of estradiol is this absorption can be decreased when you use sunscreen application. So if you apply estradiol and you apply sunscreen after the estradiol, the absorption decreases, but they claim that when you do it in the other way around, it's not affected. So this basically creates another level of complexity, because now we are talking about reapplications. So like, like I usually, my last step of skincare is my sunscreen. And after that comes my makeup. So now I need to basically change that to have this. So important things to take in consideration. As I say, like there are indications that topical estradiol can be absorbed into circulation. There is indication that active estrogens can stay that is not absorbed, can stay in your hands and basically be transferred to kids and pets. And hence, like this is not your regular a skincare active. Is a skincare active that you will take very seriously because it's an active hormone. So before we close this chapter on estrogen, let's talk about isoflavonoids. So isoflavonoids are a class of like compounds that are biologically active, and they are also referred, some of them are also referred as phytoestrogen. Why? Because these phytoestrogen have the capacity of interact with the estrogen receptor and produce similar effect to 17-beta estradiol. So that means that, if we want to have the same effect of estrogens in our skin as in a topical product, we can bypass the active hormones with all the risk of, like absorption into circulation or transfer to unwilling receptors such as child and pets, and we can use these phytoestrogens. So the most famous phytoestrogen are, like contained in soy, lentil, and red clover extract, and the most potent ones is genistein, and genistein bind to the estrogen receptor beta, which is the most abundant in the skin. So it kind of like making, sense to try, if you want to do this path, to try isoflavonoids rich skincare. So there are a few clinical studies. Most of them, they use 4% genistein, and they are between 12 and 24 weeks on postmenopausal women. And what they observe, an improvement in skin dryness by increasing your own hyaluronic acid, a decrease, in skin roughness, a reduction of wrinkles, an increase in skin thickness due to collagen 1 and 3, and there were not reported systemic effects. So this is a good, like thing that you can do. So you can see, which are the skincare that contain, extracts from, soy, lentil, or red clover. Now, the most famous phytoestrogen that everyone is in love, but everyone is unaware that is a phytoestrogen is bakuchiol. So if you are using bakuchiol, you are addressing already this pathway. Okay, final thought about this. We know that estrogen is key for skin hydration, barrier function, sebum production, collagen, and elastin level. That is your normal estrogen, what you produce and you use your entire life. We know that hormone replacement therapy produces benefits on the skin through an increase, but produce an increase in the risk of breast, endometrial, and ovarian cancer. So it has to be done properly. You have so many other actives that you can use for, anti-aging that can be, beneficial without the risk of this type of cancer. Topical estrogen improves postmenopausal skin health, but the results are not very impressive. So I will take my retinol every day, my growth factors, or my, any of the products that I produce, before putting a cream with estrogen on my skin. And if I really want to see the effect of estrogen via phytoestrogen, I can use Bacushol. So the risk is too high for me to use this as an anti-aging skincare active. And the final point, that is linked to what I was saying, is like the systemic effect of topical estrogen are not fully understood. And there are studies that are saying that this does not go into circulation, but there are studies that show that it actually goes into circulation in forms of cream gels, when you apply it as a cream gel or as a patch. So there is a potential role of, getting into circulation, and this is not the place to be as a skincare product. So if you ask me, I will not use estrogens as an anti-aging. I will, as I say, probably go for a phytoestrogen if I want to address that pathway. And if you have any questions, you have here my, social media. You can find me on Instagram or send me an email directly to my email address here. So I hope that you enjoyed this presentation. It was a little bit tedious because we reviewed so many papers, but I think it was important to show what was published in the literature as peer review communication. So take care, and we will talk soon.